We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, APIC.
Join us as we speak to those in the field of infection prevention and control like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Now, Nikki, I don't know about you down in Kentucky, but up here in New Hampshire, we are ready for spring. We're expecting yet another big snowstorm, 12 to 18 inches.
Oh my
gosh.
I
feel like winter and spring are just battling for domination.
Well, I can tell you here, I think spring has won. Spring kind of came into April like a lion. So we're definitely dealing with lots of wind and storms and rain and damage and downed trees, beautiful, beautiful old trees. So I can feel that battle, and I'm sorry to hear about it. Are you over the snow?
We are not over the snow. It is coming down as we speak. So
no, are you personally over the snow?
Oh, I'm over the snow. I've had enough. Yes.
Okay, well, I'll just get my snowshoes on and come on.
Come on for a visit. Well, today our guests are Kathleen McMullen, Jessica Banks, and Angela Gray. And I'm interested in hearing, are you ladies team winter or team spring?
It's Kathleen. I'm team spring because it's that time of year. I'm always excited for the changing of the season. So next summer, I'll be team fall and winter again, though.
Yeah.
This is Jessica. I am definitely team spring. I love all the colors and the vibrance of the tulips that are coming up. I'm definitely team spring.
Same here.
This is Angela. So I'm the oddball out. I'm team winter. Yeah. I'm anti. There's a reason for the cold, and it's snow, and it's beautiful, and it's fresh and clean. And
I've always said if it's going to be cold, it might as well be pretty. So I agree with that, Angela. I'm not team spring or winter. I am team anti-summer.
Mm-hmm. I'm team summer, actually. If I had to pick one, I would be team summer.
Really? Jesse, we really do need to switch places.
I'm team summer and I'm team Christmas. So however that works. Well, anyhow, we're really excited to hear more from our guests today on their article, Development of Infection Prevention Program Standards for Critical Access Hospitals. So I'm going to kick us off by telling you a little bit more about our guests. Kathleen McMullen received a bachelor's degree in biology and a master's in public health concentrating in epidemiology and biostatistics from St. Louis University. She is the Director for Infection Prevention at Mercy, coordinating efforts for 45 hospitals and healthcare facilities in Missouri, Arkansas, Oklahoma, and Kansas. Kathleen is board certified in infection prevention and control and a fellow of APIC. She is a past chair of the APIC Practice Guidance Committee and has held several positions on her local APIC chapter board. She is also a fellow of FSHEA and a member of FSHEA disinfection and sterilization guidelines and AMI guideline committees. She has been a presenter at APIC, FSHEA, and ID Week national meetings and is the author of many IP-related papers and abstracts. Jessica Banks received her nursing degree from Crowder College in Cassville, Missouri. She is the infection preventionist for Mercy, Aurora, and Cassville, two critical access hospitals in Southwest Missouri. Jessica was just elected this year to the board for the Southwest APIC chapter. Jessica has worked her way through the healthcare system in her 18 years of service with Mercy and started infection prevention in 2020. What a year to start. She is a member of MOAHQ, MOSHE, and APIC. And then we have...
Hold on, I want to know.
I know, I knew you were going to say, what were those?
Well, I don't know what they are.
I don't either.
What are those? The Missouri Healthcare and Quality, and then MOSHE. We call it MOAC and MOSHE and APIC.
And we have Angela Gray, who received a bachelor's degree in psychology and a bachelor's degree in nursing, both from the University of Oklahoma.
She is the infection prevention specialist for St. Luke's of Duluth, now part of Aspirus Health, covering the acute care facility, 28 clinics, 3 ambulatory surgical centers, and a critical access hospital. Previously, Angela worked with Mercy in Oklahoma, overseeing the infection prevention programs for 3 critical access hospitals. Angela became board certified in infection control in 2011. She continues to be a member of APIC, Oklahoma Chapter 125, and now the Minnesota Chapter 18. Angela has also been a member for a local Oklahoma organization called Epidemiologists and Preventionists in Infection Control, otherwise known as APIC, having served as their president, board member, conference committee vendor coordinator, program coordinator, and most recently, the website administrator. Very cool. So we are very excited to have all 3 of you here with us today to talk about IPs in critical access hospitals. This is something that I think comes up in conversations with me a lot, as this is not a topic that we often hear about. So I am super excited. And I'm hoping that Kathleen, you can kick us off and tell us what the catalyst was for developing these IP program standards specifically for critical access hospitals.
Sure. And thank you so much for having us. So we really came together. We recognize that this need exists specifically within our critical access hospitals because our infection preventionists in these hospitals are often pulled in several different directions. Sometimes they aren't trained in IP or have very superficial IP training. And some of us are not sure about standards and what all that they should be doing to ensure safety from infection with their patients. So our goal with all of this was to help them identify standard work, tests, and what they needed to do to be successful.
Yeah, it is awesome. And I think there's probably a lot of people that think because critical access hospitals are small and they might not offer all the services that a community hospital or academic medical center offers, that the breadth of infection prevention work is a lot smaller. So tell us what that really looks like.
Well, this is Angela, and I'll take that. So the fact is that critical access hospitals really have a ton to offer. And in fact, some have surgical services. So all this is really provide for the patient where they are and keep them close to their health and their community support. So all that, as well as it's known that rural areas seem to have lower incomes, putting them at higher risk for poor health. The resources that critical access hospitals have are considerably fewer than the larger facilities. So an IP who may have training can make a large impact on the care and the outcomes for those rural area patients, including education that helps that patient after discharge. There's no shortcuts in the tasks that IPs have to do to help achieve that. And having that IP that can network with APIC and other IPs is a really big asset. So just because they're smaller doesn't mean they have less.
Oh, yeah. Those connections are even more important. Absolutely. When you feel like you don't have that support level. And, I also appreciated that the paper noted most of the literature around staffing models hasn't addressed those critical access hospitals and people working in those areas. So I know it certainly leaves a gap for the over, 1,300 critical access hospitals in the U.S. So, how do you even begin your work? Who was involved?
This is Jessica. I'll take that one. And I just want to say it really started off by Kathleen and all her efforts to make our ministry IPs feel included. That is one of, I believe, a goal that she set when she first came into her position, and it's been amazing. She included a variety of critical access IPs, some that had one hat in one facility. So maybe they were just at one IP in one facility, or maybe they had, one hat, but maybe had multiple facilities. I believe that was Angela. She had 3 facilities, but she was only IP. And then there were some others, kind of like myself, where you have to wear multiple hats for multiple critical access hospitals, like education and IP or different things like that for multiple facilities. So I remember when I first met Kathleen, I was kind of taken back by the way that she listened to the critical access hospital concerns. And she not only listened, but she acted. And that was bringing all of us together. Kathleen kind of has stood behind everything she's ever taught me as a IP. And so when you have someone like that leading the charge, it's really easy to kind of stand on the front lines and go into any battle.
Oh yeah, that support is vital. And that's great that you had somebody there to bolster your work. That's great.
Yeah, that's fantastic. And as part of a health system made up of an assortment of different size hospitals that offer a variety of different services myself, I can definitely appreciate that collaborative approach to the work. And the article states that after the group detailed the daily, monthly, and sort of miscellaneous work in detail, that they reviewed the APIC-IP competency model. And can you just talk a little bit about how that model helped with the development of the standards?
Sure, absolutely. The model was helpful kind of throughout the project and has been helpful to us since the project has completed. So as we said, the model helped really guide the framework as we started meeting and talking, and I was hearing from all the IPs what they were doing. Following the framework of the competency model really helped me make the notes and our eventual standard work into something that makes sense and sort of follows the different domain competencies of the IPs. We also used it at the end to go back and make sure we hadn't missed anything. And to be honest, one of the things that we had missed or needed to bolster up was the professional development piece that's at the bottom. So the competency model is very well written, and it was definitely necessary to make sure that our program was well-rounded. At the end, it really helped to lend credence to our work. So as we were sharing this work and this framework with all of the IP's leaders around our ministry, having that published document by a national organization as the backbone was definitely helped everybody understand the importance of what we were saying.
That's great. And it's fantastic that we have this professional organization that provides tools like the IP competency model to help IPs build and maintain these successful programs. How did these changes impact the number of FTEs that were then allotted to each hospital in the system?
Yeah, so they moved more toward the hours or time allotted for specifically toward that IPs, which for those that had the other hat that they were wearing, they got a little less attention. I think that the model with an IP covering multiple hospitals seems to be the most supportive of the work. From my perspective, having those 3 facilities and that one role was best fit for the program. I gave it more quality and it was more effective from my perspective. I think a lot of my colleagues would agree with that. However, there are some really talented and time-managed people that can manage multiple hats at multiple facilities like Jessica does. But I think overall, if you're going to have multiple facilities, one IP to cover those, to give them that big focus in is where they really need to be.
You know, it was noted that an extra 78 hours were allotted over a year for ENDO and OR. So what were the activities that compromised that amount of?
That was primarily activities spent rounding, auditing, giving feedback, keeping up with the standards, endoscopy, of course, keeping up with the AMI standards, OR, keeping up with AORN standards.
That feels like a full-time job in and of itself. That is so much.
And, to go back on the theme of what we're saying, just because you're a critical access hospital that only has 1 or 2 endoscopy rooms, you have to know the exact same amount of knowledge.
Right.
And spend
exactly.
a lot of time down there, just as if you have a 20-room endoscopy unit.
Yeah, you absolutely do. And I mean, given all of what these positions have to do, how did you get hospital leaders on board with the change?
So we started out with just a big meeting where we explained what the model was, and we invited hospital leaders as well as the IPs and answered a lot of just superficial questions. And then we gave everyone about 3 months to chew on it. We came back together and did individual hospital meetings after that at the 3-month time. So I myself, as the system director, met with the IP at one hospital and their immediate leader at their hospital. And so I did that with each individual hospital. That really allowed, I think, even more understanding, more time to ask questions after they've been looking at this for 3 months and been digesting it. having those individual conversations really allowed us to focus on what opportunities for growth there were still within the program, as well as celebrate the successes of each individual hospital. We then gave it another 6 months, came back together at 9 months. We're actually getting ready to do an 18-month roll as well. But when we came back at 9 months, we were able to, it was very exciting that we could see the improvement, the more FTE hours being shifted toward IP from other responsibilities, and more detailed information on the couple of opportunities that still may have existed, always different between different hospitals. There was always some that were more able to be focused on environment of care and others that were more able to be focused on devices, whichever it was. And then these continued meetings have also really helped us. We've been adding some tasks. I know my poor IPs probably want to string me up, but there is always more for IPs. There are always additional opportunities for us to get involved. So I'm able to, when using these meetings and when having this audience with their senior leaders, explain why it's important for the program to further expand as well.
I'm curious, you covered it a little bit, but I wonder what the agendas were for those 3 and 9 month check-ins.
The 3 month was very, very open. The 9 month, they were very specific to the hospital. Whatever, opportunities we had identified at the 3 month, that was the first thing we checked in at the 9 month, as well as, the new things that we had added that time.
Can I backtrack just for a second? I'm just curious, like when you talked about you have IPs that are covering these multiple hospitals, how were they already covering multiple hospitals prior to the development of the standards?
Yeah, this is Angela. I've had the 3 hospitals when we started this, and I think most of them did.
It just so happens I have my 2 multi-hospital people here. So Angela only did IP for 3 and Jessica did IP in education for 2.
Only did it for
right.
3.
Well, and so my curiosity about this is that this is not something that I've currently experienced in our healthcare system, but I'm curious. So after the development of the standards, I guess this is a great question for Jessica and Angela. Do you feel like it sort of streamlined things or made tackling the program easier? Like, how did you find this impacted having to cover multiple hospitals?
This is Jessica. I can start off. I felt like it was really impactful, especially when we had the 3 and 9 month meeting with my leader. My leader here, she does quality. She's never been an infection preventionist. We both kind of came into our roles right in the middle of COVID. So we were both kind of just figuring out what we both were supposed to be doing. So this to me gave her so much insight to what is all involved for an IP for critical access hospital. And so it really made our one-on-ones more meaningful because she could wrap around everything that I was doing behind the scenes without having to try to micromanage. Because to try to keep track of somebody going to 2 different facilities or 3 different facilities, it can be a little mind-boggling. But so I really I think it just really gave her a good idea of what all is encompassed into that job role. Plus knowing that I also have another job role. And so when things became difficult sometimes between those 2 job roles, she had that understanding of why.
That's awesome. Angela, did you have anything you wanted to add?
Actually, I have been an IP since 2011. So when I started with Mercy and I took on those 3 critical access hospitals, I came from it's not a large, it was a mid-size acute care facility. So I was learning how to manage those 3. So I kind of went with it. And then I learned how to standardize across those 3. So I had to time manage better. And so when we put the program standards together, I could kind of already tell how much time I was spending on each area at each hospital. So I would have to split the time. So if I'm reviewing my surveillance, then I'm doing all 3 at one time. So that was beneficial in us building this because if I weren't at 3, how much time would I be spending at the one. That's where my insight came from. So it was very beneficial for my direct leader as well, because she did not realize how much I was actually doing behind the scenes, that she was a quality person as well, and still learning some of what I was doing. And a lot of the data that I provided them was in a different format than they were familiar with. So it was a learning experience for them and for me, well, for critical access.
I think it's really cool because I think, to your point, people within the hospital don't always know exactly what it is that the IPs are doing. So having these standards available to illustrate, the work, because in my mind, not being part of a critical access hospital, but coming from an academic medical center, I always think sort of what I think Kathleen pointed out earlier, which is you don't have to know less, and you still have to do the majority of all the same things that an IP at a larger hospital would be doing. So in my mind, it always felt like almost like a heavier lift for that person who's covering that hospital. So it's your experiences. That's great to hear that this has been helpful. Now, the hospitals didn't just develop and implement standards. They tracked a variety of metrics. How did you determine which metrics you thought would be important to track?
This is Angela. I'll take that one. So coming from the larger facilities, they usually use SIRs. Well, in a critical access hospital, we kind of have to track those by number of events or the standard utilization ratios, or the SURs, because of the denominator being so low or the number of infections being so low. Sometimes the SIRs don't even calculate.
And so the paper notes that there was a positive impact on infection data trends for all of the critical access hospitals combined. Can you highlight some of the successes that were observed?
Yeah, I can talk about some of our bigger ones. Well, our catheter-associated urinary tract infections, they decreased. We call those CAUTIs, decreased 69%. While our C. diff infections decreased 24%. And then our central line-associated bloodstream infections, CLABSI, they did not decrease in this time frame, although there was only one case of a hospital-acquired infection in both 22 and 23 for the hospitals all combined. So definitely saw a great impact on some of our more renowned infections in the hospital.
That's awesome.
It is. And let's talk about those decreases in the CAUTIs and C. diff. Why do you think that those specific hospital-acquired infections decreased?
So one of the things that I've been working with to help with is C. diff infections in our hospital. And with this standard of care, we've been able to just have more one-on-one with our staff, more one-on-one with our leaders. And I think that by itself just helps us to be able to bring down those infections, because we're working as a team. Obviously, one IP can't, make all the C. diff rates go down. But if you're able to do your observations and your rounding and be able to have one-on-one with that staff and just have those connections of the staff to try to help them figure out why it is so important, I really think you can help reduce those rates. But sometimes with critical access hospitals and wearing multiple hats, some of those job duties don't get attended to as well as they could because of those different hats that you're having to wear. So some things don't get attended. So when the leaders can see that in this document, they're able to know that more time needs to be dedicated to the education and the one-on-one observations with the IPs and the staff.
Yeah, that really makes the case for focused IP work in employment, I think. And I think one of the successes is highlighted by this direct quote from a leader. This is certainly eye-opening related to all the work needed in this position. And there was a quote from an IP stating they were, quote, excited to have more support and spend more time on IP based on this document. So not to mention positive feedback from a regulatory surveyor about the quality of the IP program at one critical access hospital. So well done. Do you feel that this was felt across all the critical access hospitals?
I would say absolutely. But we included those direct quotes because we couldn't say it better ourselves, but we received lots of accolades from the leaders, lots of accolades from lots of comfort from the IPs themselves at having this available to them. And it was widely successful and adopted at all of our facilities.
Fantastic. Kudos, guys. That's great.
Yeah, I think it's absolutely wonderful. And I look forward to being able to share this with my colleagues as well, because I know they're going to love to see the table of standard work that you included in the article. And I know our listeners can't see it as we're talking about it, but I encourage you to definitely check it out. It's very comprehensive. And I also love the fact that you talked about having professional development in there, which I think is so critical. Do you ladies have anything else that you would like to emphasize about the table or about the article today?
I would just say in general, it's always flexible. There are solid numbers in that table about amount of times that tasks should take, but it was never the same at any critical access hospital. It's meant to be a guide, and anything you can do to make this work in your environment will be helpful.
Yeah, and I'll have to add that I am covering and consulting for a critical access hospital here in the north of Duluth and 2 harbors. And I've shared this table with them so that we can make that program there a little more robust and give them the resources they need.
But thank you, Kathleen and Angela. And before we say goodbye, are there any key points that you wanted to leave listeners today with, Jessica?
Yeah, I just wanted to let them know how validating this information can be for any IP, especially critical access IPs, as you work individually at your facilities. A lot of the time you don't have a lot of backing. So that's why it's great to be with APIC. But this can also give you a lot of validation in your job. I know sometimes there's those crazy times when we don't know if it's us crazy, the job crazy, what's crazy, but this was very validating. And I just want to give some honorable mentions to back when you had asked about who was all involved. We had a lot of other critical access hospitals that were involved. We had Taylor Staggs, RN, Randy Brown, Ann Reisinger, Tamber Searles, and Megan Peters that were also involved in this. And then as one quote that I like to end everything with is just wash your hands and say your prayers, because Jesus and germs are everywhere.
Awesome. Thank you guys so much for being with us today. This is absolutely amazing work.
Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
APIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at APIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Althan and Carolyn Schneer. To hear other APIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, apicscienceintopractice.org. That's AJIC scienceintopractice.org.